Urine has been studied for centuries to obtain information about the health status, and the diagnosis of renal and metabolic disease is aided by the routine urinalysis. The onset of many diseases may be asymptomatic, meaning you're showing no signs or symptoms. So many times in a routine urinalysis, which is a very inexpensive test, we can detect abnormalities before symptoms occur, evaluate and monitor after the effectiveness of treatments, and monitor disease progression. Kidney diseases are often classified into 4 types based on the morphologic component initially affected. As the disease progresses, other components of the renal system may also be involved. The morphologic classification are glomerular, which most often the changes are due to an immune-mediated reaction. Tubular and interstitial both result from toxic or infectious substances that cause changes. And vascular, this is caused by a reduction in renal perfusion, the ability to get oxygen to the tissues that will induce morphologic and functional changes in the kidney. Glomerular diseases are diseases that damage the glomeruli, and they include immunologic, metabolic, and hereditary conditions. Nephritis is a condition in which the kidney nephrons become inflamed, and this is an indication of glomerular disease. Inflammation, unfortunately, will adversely affect the function of the kidneys. And there's 2 types of glomerular diseases. There's primary, which is specifically affect the kidneys, and often that's the only organ involved. And the primary diseases consist of several different types of glomerulonephritis. Secondary glomerular diseases are systemic diseases that initially and principally involve other organs, but also affect the kidney, such as in diabetes. There are 4 distinct morphologic changes of the glomeruli which are recognized, and 1 or more of these changes accompany each type of glomerulonephritis and form the basis for the characterization of the disease, to classify the disease. Cellular proliferation, this is increased numbers of capillary, endothelial, mesangial, and epithelial cells in the glomerular tuft. Leukocyte infiltration, where leukocytes and macrophages are attracted by a local chemotactic response, and this will result in inflammation. Glomerular basement thickening, any process that results in enlargement of the basement membrane, such as immune complexes being deposited or changes which occur due to diabetes. And hyalinization with sclerosis. This is an accumulation of homogeneous eosinophilic extracellular material. In glomerular disease syndromes, proteinuria, protein in the urine, is a common manifestation of kidney injury, and this includes both tubular injuries and glomerular injuries. Glomerular diseases interfere with the normal function of the glomerular filtration barrier and unfortunately can increase protein excretion. Protein should be reabsorbed by the body, and this can rise above 2 grams per deciliter. Nephrotic range proteinuria exceeds 3.5 grams per deciliter in adults. When damage is done to the glomeruli, the clinical features include hematuria, there will be blood in the urine, proteinuria, excessive protein in the urine, which should not occur, oliguria, which is decreased urinary production, azotemia, this is elevated blood urea nitrogen and creatinine, and the BUN is a test done on the blood. Edema, swelling, because in some instances you're retaining the water, you're not excreting it enough. And hypertension, high blood pressure can really have a negative effect on the kidneys. The severity of each feature and the combination that are present, not all of these will be present, depends on the number of glomeruli involved, the mechanism of the injury to the glomeruli, and the rapidity of the disease onset. Nephrotic syndrome is a group of clinical features that occur simultaneously, and unfortunately this has caused increased glomerular permeability that allows plasma proteins to cross the glomerular barrier. They should be retained, reabsorbed by the body. The laboratory results that are indicative of nephrotic syndrome include heavy proteinuria, greater or equal to 3 grams per day, and this appears as at least a 3+ or higher on the dipstick. Hypoproteinemia, a decreased amount of protein in the blood, and primarily albumin, and this is due to the loss of the protein in the urine. Hyperlipidemia, which is high fats in the blood, primarily cholesterol, which is produced by the liver in response to the proteinuria. Lipiduria is fats in the urine, and when you look at the urine microscopically, you may see mild hematuria and fatty, waxy, and renal tubular epithelial cast. And in the person, physiologically, edema is present. Glomerular nephritis, inflammation of the glomerular, is a group of diseases that injure the glomeruli. When the kidney is injured, it cannot get rid of the waste and extra fluids, and that is the purpose of the kidneys. It's your little filtering machine to remove toxins from the blood. This can be an acute or chronic condition, and it can occur on its own or as part of another disease such as lupus erythematosus or diabetes. The signs and symptoms will depend upon whether this condition is an acute or chronic form. An acute is a sudden onset versus a chronic that you deal with for a long period of time and perhaps for the rest of your life. And of course, the cause of the condition. The first indication that something is wrong might come from symptoms or results of a routine urinalysis. This is a picture which illustrates a normal kidney on the left and then a kidney with glomerulonephritis on the right. And all the red areas indicate the inflammation of the glomeruli and of the small blood vessels. And again, inflammation can lead to serious problems in the kidney. This is a list of the predominant forms of glomerulonephritis, and they're classified based on the characteristic anatomic alterations to the glomeruli. I'm not going to read the list to you, but I want you to know, number one, there's a lot of different types. Glomerulonephritis is a term that's used to indicate inflammation of the glomeruli. But, again, there's many different causes. No, that's not right. The types of glomerulonephritis are classified on the basis of the characteristics, anatomic alterations to the glomeruli. And here is a list of the predominant forms. I'm not going to have you make yourself be familiar with all of these. We're going to talk about the ones that I think you need to have a little bit more knowledge about. Acute glomerulonephritis, again, just by definition, is a sudden onset of the disease. And rarely this is caused by streptococcal infections, and it's known as acute post-streptococcal glomerulonephritis. This occurs 1 to 2 weeks after a streptococcal infection of either the throat or the skin. It appears most often in children, but can occur in any age group. And only certain strains of group A beta hemolytic streptococci with M protein in their cell walls induce nephritis. And this is the bizarre component of the disease. An immune antibody is produced in response against strep, and it reacts with the M protein. Because there's an M protein that's very similar in the kidneys, this antibody cross-reacts and causes inflammation and damage. Although most patients will recover, there is rare long-term kidney damage or failure which can occur. And this is why if you think you have strep throat, it is crucially important, number one, to go to the doctor and be diagnosed. Number two, take the medication for the length of time you are supposed to. Because if you don't, the strep can come back, or if you don't treat it, it can travel to other parts of your body, primarily the heart and the kidneys. We're going to talk about systemic diseases with secondary glomerular damage. Systemic diseases are diseases which don't affect just one part of the body. They are systemic. There may be multiple organ systems involved. One of the classic systemic diseases is systemic lupus erythematosus. This is an autoimmune disorder causing the immune system to produce antibodies which attack the individual's own tissues and organs. They are autoantibodies. And we learned in serology and immunology that antibodies are supposed to react with non-self antigens. But this is when the immune system goes wrong, and unfortunately, the antibodies that are produced against self. In SLE, this antibody formation and the reaction leads to immune complexes being formed, which are then deposited in the kidney basement membrane. This then activates complement that leads to inflammation, which will result in nephritis. This may lead to chronic renal failure and is the leading cause of death in patients who have this disease. Diabetes mellitus, this is a carbohydrate metabolism disorder that leads to glomerular syndrome, hypertension, and susceptibility to pyelonephritis. Glomerular syndrome causes inflammation and scarring of the glomerulus, leading to the kidney failure. It's more common in type 1 than type 2, and unfortunately in diabetes mellitus type 1, renal disease is a major cause of death. Amyloidosis is a systemic disease involving many organs, and it's characterized by deposits of an abnormal protein called amyloid, which is a pathologic substance to the body. Amyloid is not normally found in the body. It's formed from several different types of proteins. Unfortunately, these are deposited and build up in organs and will interfere with their normal function. The deposition of amyloid within the glomeruli will eventually destroy them. This will lead to proteinuria and nephrotic syndrome, and it may lead to renal failure and uremia. In tubular diseases, the condition known as acute tubular necrosis, or ATN, is characterized by destruction of the renal tubular epithelial cells, and the causes of ATN vary, and there's two types we'll discuss. Ischemic ATN is followed by a hypotensive event that causes decreased perfusion, decreased oxygen to the tissues, and this can be a result of sepsis, shock, or trauma. So without oxygen, eventually your tissues are damaged and die. Toxic ATN can be caused by exogenous, outside substances, or endogenous substances that are in your body already, nephrotoxins, and these will then cause tubular necrosis. Some of the endogenous substances which are toxic at high concentrations include hemoglobin, for example, an incompatible blood transfusion. One of the downsides of an incompatible transfusion is the hemolysis of the blood, the release of massive quantities of hemoglobin, which are toxic to the kidneys and cause their shutdown. Myoglobin results in rhabdomyolysis, and this is a breakdown of the skeletal muscle. So those are endogenous substances. Exogenous substances are those which are ingested or absorbed and are usually due to a number of therapeutic agents. And one of the end testing that's done on all humans or drugs is human testing. And one thing they're always looking for is what are the effects primarily on your filtering organs, which is your liver and your kidneys. Tubular dysfunction results in the inability to generate appropriately concentrated urine in response to a physiologic stimulus. So again, all that transfer, we retain certain elements within the tubules in different parts of the tubules, the proximal, the distal, the loop of Henle, and this exchange is going on all the time. So when we have tubular dysfunction, then that can result in a lot of different conditions. So what I want you to know about these conditions is what is the name of it and what is occurring due to this disease. So these are inherited disorders which result in excessive loss or retention of certain substances. Fanconi syndrome, this is a generalized loss of tubular function. So amino acids, glucose, water, phosphorus, potassium, calcium are not reabsorbed. This is not a good thing. These are all essential elements for your body. And again, these are inherited disorders. Cystinosis and cystinuria, this is an inherited disease that results in cysteine in the urine. Renal glucosuria, lowered reabsorption of glucose. And again, we're not talking about diabetes where we're dumping glucose. We're talking about a situation in which the glucose, they're unable to reabsorb it. Renal phosphaturia, this is the inability of the distal tubules to reabsorb inorganic phosphorus. And renal tubular acidosis, the kidneys fail to excrete acids, and this causes the blood to be too acidic. Urinary tract infections are very, very common, and urine and the urinary tract are sterile. There is normal bacterial flora that's located in the urogenital area, And when you urinate, the flushing action of urine actually prevents bacteria from entering and going up into the urinary tract. Most UTIs are caused by gastrointestinal bacteria, and I want you to know the difference between what's affected in a lower versus an upper UTI. Lower UTIs involve the urethra and bladder, and they're characterized by pain or burning on urination. This term is dysuria, and any of you who have had a urinary tract infection know exactly what I'm talking about. And there's a frequency to urinate even though the bladder's empty. You have this feel or need to go to the restroom, and you try, but you just can't produce any urine. It involves gram-negative bacteria, with E. coli being the most common. And in the elderly, if mental confusion or distress may be a symptom of a urinary tract infection. The upper urinary tract infections involve the renal pelvis. Acute pyelonephritis is a bacterial infection of the renal tubules, the interstitium, and the renal pelvis. And there's two mechanisms. One is the movement of bacteria from the lower urinary tract to the kidneys. And the second is movement of bacteria from the bloodstream to the kidneys. So you have a septic patient. The urinalysis will show bacteria, leukocytes, leukocyte and other types of casts, hematuria, proteinuria, and a low specific gravity. Chronic pyelonephritis develops when persistent inflammation of renal tissue causes permanent scarring that involves the renal calyces and the pelvis. Many diseases can cause this, but the most common is reflux nephropathies, and this is urine flowing backward from the bladder to the kidneys. And if there is a UTI going on, bacteria-laden urine can then cause upper urinary tract infections. If you have recurring, repeated infections, this can result in fibrosis and scarring of renal tissues. And when you have fibrosis and scarring, those tissues are unable to perform their duties as assigned. In the urinalysis, you may see leukocytes and discover proteinuria. Bacteria may or may not be present. Casts may be present in the early stages of the disease. With more chronic type infections, this can lead to polyuria and nocturia as tubular function is lost. Acute interstitial nephritis, this is caused by various drugs and conditions, but the most common cause is kidney transplant rejection, and it's most often induced by drug therapy. Once you have a kidney transplant, for the rest of your life you are on anti-rejection drugs. And there is no drug that does not have some type of secondary bad effects. So this is one of them. Some other conditions that can cause acute interstitial nephritis include leukemia, lymphoma, sarcoidosis, bacterial and viral infections. It induces a cell-mediated immune response. So it's not your B cells or your lymphocytes, but it's your T cells that are involved in the cell-mediated immune response. This will then cause damage to the interstitium and the renal tubular epithelial cells. The tissues are infiltrated with white blood cells, leading to necrosis, because white blood cells are part of the inflammatory process, and this is the inflammatory process gone wild. The urinalysis, you may see hematuria. What's hematuria? That's intact red cells in the urine. Mild proteinuria, leukocyturia without bacteria. And there may be increased eosinophils present. So that would be a classic for this type of acute interstitial nephritis. Yeast infections are very common, and they can occur in men and women, although women are usually the more frequent targets, and the yeast is present in the vagina. Candida species are normal flora in the GI and vaginal tract, and when the normal flora is disrupted by antibiotics or pH changes, yeast can proliferate. Women will notice that when they take antibiotics for some type of bacterial infection, let's say strep throat, that suddenly within a few days they will then develop a yeast infection. Yay! Because the antibiotic doesn't know just to kill the pathogens, they kill bacteria. And so if your normal flora gets out of balance, if the good bacteria are killed by the antibiotic, then yeast can overgrow. You will also see severe and difficult to manage yeast infections in immunocompromised patients because their immune system is unable to combat these normal type organisms that are present in and on your body. And the yeast is seen in a microscopic examination of the urine sediment. Vascular disease. Kidney functions dependent on receiving 25% of cardiac output. Because, again, remember that your blood is filtered, the whole volume of your blood is filtered several times throughout the day. And if there is a disruption to the blood supply, this will then affect renal function. Changes in kidney vasculature, the veins, the vessels, will affect the interrelationship and interdependence of the blood vessels with the renal interstitium and the tubules. Disorders that alter blood vessels or blood supply to the kidneys can then cause renal disease. Atherosclerosis of intrarenal arteries will reduce renal blood flow. Atherosclerosis will cause plaques to build up on the side of the vessels, which will then make the vessels more narrow, more narrow, more narrow, so it reduces the amount of blood. Many disorders can cause significant changes in the renal arterioles and the glomerular capillaries, such that severe and fatal renal ischemia, which will result in the death of the tissue, will result. And hypertension is the most frequent condition. Acute and chronic renal failure. And in general, just remember that acute will always indicate a sudden onset of a disease, whereas chronic is it comes back periodically. So in acute renal failure, there's a sudden decrease in glomerular infiltration rate, which results in azotemia and oliguria. There's functional abnormality, but no cellular changes, and it's classified as pre-renal, renal, and post-renal. Chronic renal failure is a progressive loss of renal function, and this may be due to hypertrophy of the remaining healthy nephrons. They just shrivel up and are no longer functional, and it's not clinically recognizable until 80 to 85% of the nephron's function is lost. Azotemia, acid-base imbalance, abnormal calcium, and phosphate metabolism occur. Renal calculi are also known as kidney stones, and these are aggregates of mineral salts and a matrix of proteins and lipids. And 75% of renal calculi contain calcium. They're found primarily in the renal calyces, the renal pelvis, the ureters, or the bladder. There's an absence of natural inhibitors, which is postulated as a potential cause. And some people are more prone to them than others. I myself have never had a kidney stone. I've known other people who, throughout their adult life, have been plagued with these being formed and produced, and then they have to get rid of them. There's 4 factors that will influence calculi formation, and it's the supersaturation of chemical salts in the urine. It has to have an optimal urinary pH for the formation, urinary stasis where the urine isn't flowing as it should, and this is why whenever you have the urge to go urinate, go. Women we just try and hold it and hold it and hold it until the last minute. Number one, that can lead to kidney infections, and the other one is if you are prone to kidney stones, this can enhance their formation. And then you have to have nucleation or original crystal formation. This is a table that lists the frequency of the different types of kidney stones by what they are composed of. And when these kidney stones are formed, you may see in the urine these crystals that appear, because they are components of the stones. This is the end of part 1. I want you to review your textbook. Your textbook goes a lot farther than what I want you to know, so really focus on your objectives, focus on the information presented in this